The initial treatments that we think about for liver cancer, always I want to think about curative treatments first, which would be resection or transplant, or potentially ablation in the very small tumors less than 2 centimeters. When we think about eligibility for resection, the big thing for that is underlying liver disease, and is the liver with cirrhosis going to be able to tolerate a resection? That has to do with the liver function as well as portal hypertension, but also how much liver is going to need to be resected and the volume of the remnant liver that will be left behind. For this patient, he's not a candidate for resection because he has metastatic disease. But if he did not have metastatic disease, we could potentially look at whether he would have portal hypertension, an elevation of his bilirubin, the location of the tumor, and whether resection would be an option. As far as transplant, the first step is really, are they within what we call the Milan criteria? And that is the initial liver cancer rules that we have to follow for transplant. So that's 1 tumor up to 5 centimeters, or up to 3 tumors less than 3 centimeters without vascular invasion or extrahepatic spread. So because he has extrahepatic spread, he is not a candidate for transplant. Now, his liver only has 1 4.5 centimeter tumor, so if he did not have that extrahepatic metastatic disease, he potentially could be a candidate for liver transplant. Sometimes we'll also take patients who don't have metastatic disease or extrahepatic spread, but they're outside of the Milan criteria, and we'll treat them to try to what we call downstage them to within Milan criteria, shrink the tumors, ablate them, taste them, do something like that, and try to bring them into the Milan criteria so then we can offer transplant as an option. Multidisciplinary teams are very important with the management of liver cancer. As you can see, obviously we're taking care of cancer, but we also are taking care of underlying liver disease. We have to involve our surgeons to determine resectability or transplantability, our radiologists, our IRs, our radiation oncologists. So it's very important to interact with all of these different specialists. The best way to do this, and the way that we do this, is we have a multidisciplinary tumor board every week that we bring these cases to, and we discuss them as a group. Any initial treatment that we have for a new presentation or recurrence, we bring to our multidisciplinary tumor board to really offer that multidisciplinary treatment planning. And the data has shown us that patients who are offered multidisciplinary treatment planning approaches have better survival, better availability of treatments, and better responses to therapies. When we're thinking about frontline treatment for metastatic liver cancer, we have several systemic treatments available now. Many places would think about doing local regional therapy with some systemic treatment, but given that he has really not a lot of disease in the liver and metastatic disease, I think that systemic treatment with some kind of oral chemotherapy is the way to go. Our options include right now lenvatinib or sorafenib as our 2 options. Immunotherapy may be an option in the future, but right now it's only approved for second-line treatment, so patients who have already failed or are intolerant to first-line. Lenvatinib is a good option for this patient because he's symptomatic. So lenvatinib does have a better response rate, meaning better tumor shrinkage to patients with liver cancer. And so those patients who present to me with symptoms such as pain or discomfort in the abdomen, I try to offer them and think about lenvatinib as a frontline, because if they get that tumor shrinkage, that may actually help their symptoms.